Good morning, everyone. Welcome. We're glad you're here with us today. We're going to wait till everyone joins. We'll get started in just a few minutes. Thank you for joining us today. We'll just give it a few more seconds, make sure everyone's in, but we're so happy you're here with us on this Thursday morning. All right, it's a minute after, and we're going to start. So, hi, everyone. Let's get started. My name is Desiree Behringer-Carton, and I'm the Director of Regional Integrated Marketing for the American Cancer Society. It's my honor and pleasure to welcome you to the event today. So I'm so happy to be here with all of you. And we ask if you've called in from a phone or have multiple people listening from one line that you please enter your name and organization in the chat so we have a record of your attendance. So please do that. All lines will be muted during this program, and we ask that all questions be entered into the Q&A tab on your screen. So we will be taking questions during the panel discussion at the end of time, at the end as time permits. So please do that. If we do not have time to answer your question during the panel, we will work with the presenters to have your question answered post-event. So thank you for that. All right. So we're going to start with our first poll question. Please answer our first poll question. What is your role sector as it relates to cancer? What best describes your relationship to cancer? So please do that. We'll get that going. We'll have several poll questions throughout the program, and we appreciate your participation. So thank you for that. I know we have people from everywhere, and we love seeing everyone puts in the chat where you're from. So before you'll see that 65% of you guys are from hospital systems, but we have folks from everywhere, from community organizations, from health departments in the states, cancer survivors. So thank you for joining us. Okay, so before we begin our program, we wanted to recognize and thank our amazing sponsors. Without the generous support of the Ohio State University Comprehensive Cancer Center, the James Cancer Hospital, and United Healthcare, this program would not be possible. So also a big thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. So thank you to everyone. So here's our agenda. We have a full one, jam-packed. We will have an American Cancer Society volunteer speak on our Road to Recovery program, followed by 4 presentations. After the presentations, the speakers will join our panel discussion, and then we will conclude with information on our American Cancer Society resources. So the AAFP has reviewed Navigating Social Determinants of Health in Cancer webinar and deemed it acceptable for up to 2.00 enduring materials, self-study AAFP prescribed credits. So you will receive a certificate to claim your CEs within 2 weeks following completion of this the post-event survey. So our objectives for today's event can be seen on the current slide. So please note that planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organizations that may affect balance, independency, objectivity, or scientific rigor for this CE event. Also, please know that the slides will be available after the presentation, and this event is being recorded right now. So now it's time for our second poll question, and you see it right there. How confident are you with your knowledge of social determinants of health in relation to cancer? And then you can see, not confident at all, slightly confident, fairly confident, very confident, somewhat confident. So put your answer there. And we'll wait for your answers. And then before we welcome our very first guest, and we're very excited to welcome him in. Okay, we'll start going. Our next guest, welcome, is Richard Dickerson, a longtime Road to Recovery volunteer with the American Cancer Society. Richard is a retired IT professional specializing in business applications. In his career, he worked for Grumman Aerospace, American Institute of Physics, and lastly, for PricewaterhouseCoopers. He has 2 children and 4 granddaughters and enjoys traveling with his wife to visit them in Scotland and Texas. And Richard started driving for the American Cancer Society Road to Recovery program as a volunteer before the pandemic in August of 2019. So, hi there, Richard. Thank you so much for all that you do to support the American Cancer Society mission and volunteer, and for sharing your story today.
Good morning, everyone. Make sure everybody can hear me, I'm sure.
Yes, we can hear you. Thank you.
Yeah, I retired after about 40 years of, I retired about 6 years ago after 40 years of IT work. My wife and I had always talked about doing volunteer work. And when I retired, I was looking for something to do, but I wasn't sure what to do. Now, as you know, we are all impacted in some way by cancer, whether it be yourself, family, friends. And I have family and friends who have had cancer. And, and for the most part, they have been able to beat it. But it was when my older brother was diagnosed with bladder cancer that I found out that getting to treatments was going to be an issue. In talking with my brother, he mentioned that he was worried about getting to his treatments, and it kind of hit me. And I said, wow, that's my older brother. He was a retired engineer from Sikorsky Aircraft. Now, why would he be having trouble? And as it worked out, and I'm sure this happens as you get older, that the kids are gone. They moved away. The wife, doesn't drive anymore. And you didn't want to be burdening his friends and pulling in favors just to get to his treatments. Well, it was about that time that I saw an article in a local newspaper here on Long Island about the Road to Recovery program. And I was unable to help my brother because we don't live near each other. But I thought, wait a minute, maybe I could drive for people in my area. If my brother needed help, well, maybe there's others. So 5 years ago, I signed up to become a volunteer driver. And I looked at it as a small thing that I could do just to help others. What I did not know at the time was how many people really needed help with transportation. And I'm still shocked by it. When I checked yesterday on Long Island, there were 76 open rides. And that number doesn't even include the rides that our drivers have already accepted to take. So there's a huge need out there. And I also didn't realize that when I started driving that you'd be driving so many wonderful people. And I hear the same thing from all the other drivers. The patients are just so appreciative of getting the ride. I did not know that when I started out that what happens is you tend to drive the same people over and over again. And you start building these friendships with them. And you get to know what they need during the drive. Do they want the heat on? Do they want air conditioning? Sometimes they want to talk, sometimes they don't. They just want to be quiet. And I had a while back, I had one patient who would come into the car and say, thank God it's warm in here. You don't know how cold it is in that treatment room. It was killing me. That same person was also a very proud person and an athlete, and he was still taking tennis lessons weekly, even though he walked with a cane. So the tennis lessons, I'm sure, were just more hitting a ball back and forth. And his wife would always come along, and when you get up to the treatment center, at the entrance, the attendant would come running on down and saying, do you want a wheelchair? And I kind of get there and stop him beforehand and tell him, no, it's not necessary. He's stronger than you think. And really, it only took one time when the attendant got there and he asked him, and the patients had a few choice words to say back to him. And that's when I realized, okay, we're not taking this wheelchair. There was also another patient I'm still driving right now, and she didn't know about the Road to Recovery program. And she was using Uber to get back and forth to her appointments. Not only was this costing her a lot of money, but there's other issues when you're using a service like Uber, that you have to sit and wait for the car to get there, and you don't know who you're going to get as a driver. With the Road to Recovery program, you know the type of person who's going to be driving you. And then, as I said, you build up these relationships, and you start developing a system with them. So this patient that I'm driving, she doesn't always know when the treatment is going to end. The application that you put in a start time and an end time. And unfortunately, most facilities tend to be behind schedule, and sometimes a long time behind schedule. So you end up working a system where we text each other as she's going through her treatment to know, okay, this is having an idea when I need to be there. So when she comes out of her treatment, the car is there waiting for her. And that's important. It's one of the things that you don't want the patient to have to worry about. They know that the driver is going to be there. I also just had one driver who finished about a week ago, finished her treatments. And you're really happy that, boy, you're done. This is great. And then when I got home, I kind of said, oh, you get the thought that, wow, you realize that you're not going to be seeing them on a regular basis anymore. And you've built up a friendship, you've had great conversations. There was also one patient that I had a while back, entered her treatments, and who said to me, and she said, I mean this in a nice way, but I hope I don't have to see you for a very long time. So you may be thinking that, well, this is me, and what about the other drivers? And I have to tell you, in talking with the other drivers, they do the same thing. And may even do more. There's a lot of great drivers out there. Many of them are cancer survivors who just want to give back, and others, are looking for some volunteer work like I was doing. And with the cancer survivors, the personal conversations that they have with the patient are really beneficial. So, why do I drive? Keep driving. For me, it's the people. Uh, you meet, and you hope that you made something just a little bit easier on them. You like to think that they have the comfort of knowing that you're going to be there when you pick them up, to pick them up. Just to give a little background on Suffolk County, where I am, Long Island, outside of New York City. Long Island has two counties, Nassau and Suffolk. Suffolk is the one further out, but Suffolk is 86 miles long. So some of the drives can be a little bit of a distance. And of course, being outside of New York, we have a lot of heavy traffic. But some stats, the year to date, we've had, in Suffolk County alone, we've had 725 requests. 371 of them were fulfilled, so it's about 56%. We're hoping to get that up higher, and we have around 50 drivers now. And as I said, right now we have, if I go into the application, there are 76 open rides. And as I said, that doesn't include the rides that people have already picked up. And that's really it for me.
Richard, that's amazing. I mean, everyone is so lucky to have you, drive them. You're so caring. And thank you for all that you do. We're very lucky at the American Campsite to have such a wonderful volunteer like yourself helping so many people. Thank you.
Well, as I said, there's many other drivers that are probably even better. I mean that.
You all are great. So thank you for everything. We appreciate you. So it is now my pleasure to welcome our first presenters, Dr. Manjareen Safat and Rebecca Cami. Dr. Safat is the Assistant Director for Community Outreach and Engagement at the Sidney Kimmel Comprehensive Cancer Center and an Assistant Professor of Population Science and Medical Oncology at Jefferson. Dr. Sofat assists in the coordination of community outreach and engagement activities across the Sidney Kimmel Comprehensive Cancer Center's 7-county catchment area, as well as ensuring an appropriate bidirectional relationship between the cancer center and the community. Becky Cami is the Associate Director of Psychosocial Care and Enterprise Manager of Oncology Social Work for the Division of Supportive Oncology at the Sidney Kimmel Cancer Center at Jefferson Health in Philadelphia. She is currently pursuing her doctorate in palliative care at the University of Maryland in Baltimore. Welcome. Thank you so much for joining us.
Thank you. And so today I'm going to be we're both going to be going over integrating health-related social needs and screening in cancer care. And I'm just going to give a brief overview of different social determinants of health. We can go to the next slide, and Becky will be getting into the meats and potatoes of what we do at Jefferson. So first, I just wanted to anchor the talk by giving some examples of factors that influence health. So we know that a person's health has multiple spheres of influence, and social needs are the person's individual circumstances. We also have at the community level social determinants of health. And finally, we have systemic causes that result in social inequities. Next slide, please. So social needs are the individual's non-medical, social, or economic circumstances that hinder their ability to stay healthy. So for example, lack of housing. If you don't know if you're going to have a roof over your head for the next month, how could you possibly focus on your healthcare needs? Next slide, please. At the community level, we have social determinants of health. So these are the underlying social and economic conditions that influence one's ability to be healthy. So for example, and this is a great segue from our last speaker, if you don't have a car yourself and you don't drive, does your neighborhood have that sort of built environment that can have a bus to get you to the hospital or access to these other services? And next slide. And finally, systemic causes are the fundamental causes of social inequities that lead to poor health. So for example, racism. A great example of this is how historically and still today, districts are redlined by government officials. And this can sometimes be based on the racial makeup of people who live there. And then those specific counties might not get as many resources allocated to them. Sometimes within the same city, for Baltimore, for example, there can be a 20-year gap in life expectancy between those who live in those richer counties and those who live in those poor counties. And I'm going to pass it on to Becky now.
Thank you. And there's a lot of terminology out there in the literature and just used in practice. And so I wanted to kind of, as the first presentation, talk through some of that. So social determinants of health, as Dr. Safat went over, is probably the terminology that most are familiar with. And a lot of those risk factors are exacerbated by situations of discrimination, racism, biases. All of that plays into that systemic role that then has this downstream effect into how this impacts a patient's experience in healthcare and accessing healthcare. A newer term that's kind of come up is health-related social needs. And these are really sort of this is a nice graphic here of the different domains that are influenced by the social determinants of health, and really kind of getting more into the immediate risk factors that patients are experiencing. And so the definition is health-related social needs are conceptualized as the social, economic, and environmental risk factors that result from SDOH, the social determinants of health. These unmet HRSNs could include housing instability, food insecurity, unemployment, lack of quality childcare, utility assistance, and affect individuals' ability to maintain their health and well-being. And it's quite well established that these challenges are much more commonly experienced among systematically disadvantaged individuals. And so when we talk about health-related social needs in the context of cancer care, it's really important to understand that this is bidirectional. So we have patients who are coming in with these hardships and these social risk factors. And then we also have patients who may actually not really have these social risk factors, but the cancer diagnosis triggers a cascade of financial hardship for them and their families. And at Jefferson, we implemented a system-wide health-related social needs screening. I'm going to kind of share some tips with you all, particularly those in the audience who are maybe looking or are implementing some type of SDOH or HRSN screening at their institution. Things that have been successful for us, and we've actually increased our screening by 46% in this past quarter. And so first thing is to think about the tool that you're going to use to assess these needs. And there are a lot of different tools out there. In 2013, the National Academy of Medicine had made recommendations that we integrate into standard practice assessing for social and behavioral drivers of health. And as a result, there's several tools that have been developed over the years. Some that you might be familiar with is called PREPARE, which is Protocol for Responding to and Assessing Patient Assets, Risks, and Experiences. Then the Center for Medicare and Medicaid made their own tool called the Accountable Health Community. And there's another tool, just to name a few, called Health Leads. And what these all have in common is that they identify a broad range of health-related social needs, that they're stakeholder-driven for actionable change, they're standardized and streamlined into clinical workflows, and that they're evidence-based and informed by clinical practice. Next slide. At Jefferson, we ultimately decided to utilize the Health Leads tool. And you can see here that there are 8 domains on the right side of your screen and 1 question associated with each of those domains. So it's not a long and exhaustive screening. It's pretty easy to get through so that we're not overburdening both patients and staff with many, many questions. And it gets us a sense of if or how many of these risk factors might be prevalent for this patient as they're going through their cancer treatment. You can see at the bottom, there's 2 additional support questions. Do you want any help with any of your needs? And are any of your needs urgent? And ultimately, we decided to, as an institution, to move forward with Health Leads because there was recognition of both kind of health literacy and how the questions were framed and the language that was used. Support questions allowed for risk stratification so that the patients could tell us, yes, this is something that I do want help with, or also protect their privacy and saying, you know, yes, I do have some stress here, but I don't actually want any kind of interventions at this time regarding it. And letting us know sort of the urgency so that it's a really shared decision-making process and we're not making assumptions and thus increasing biases and stereotypes around what patients need, that we're letting them be a part of that process. Next slide. And a huge part of what makes this successful is that the screening tool is embedded into our electronic health record. We use Epic here at Jefferson, and here's some nice screenshots of exactly what it looks like. There's this nice, we call it the wheel, that really is a color-coded wheel and helps us understand what the risk is, green being low risk and red being high risk. And we can see here when this specific patient was screened on what dates on each of the domains. And this lives within the storyboard, kind of the main frame at Jefferson across not only just the cancer center, but all specialties of care among providers. And so it's a really easy way to at least draw attention to a doctor, to a care team around, hey, look, there's sort of a lot of red around this patient. Maybe there are some other stressors that might be impacting their ability to get here or might be impacting, you know, kind of just sort of life outside of cancer, and that these are risk factors we should pay attention to and ask about. Slide. And so when you're sort of thinking about how to integrate this, there's a lot of considerations to put into place. We really found the biggest success when we had some institutional buy-in. So not only are we doing health-related social needs screening at the cancer center, we're actually doing it as an entire health system. So patients are getting screened with the same tool and the same electronic health record when they are admitted to the hospital, regardless, even non-cancer patients. They're getting screened again when they go to a primary care. And so that this has really become a standard of care within our institution and not just sort of a little niche kind of quality project, that this is how we deliver care, is that we care about social needs in addition to medical factors. Within oncology, it's really important to think about other screening tools that might already be in place. So many here are probably familiar with the NCCN distress thermometer, which had really been sort of the best practice for many, many years. And, we're sort of grappling still at our institution, do we still do distress screening? At what frequency do we do distress screening? Is it duplicitous? Are we overwhelming our patients and our staff? And I think as we move forward in exploring this, the literature and sort of recommendations from professional societies will continue to evolve to sort of determine where we focus our energy and efforts in screening for social needs. Other important piece is that we are able to provide resources and interventions when we do identify a patient who has risk in one or more of these domains. And this is really important to think about your specific cancer center and the resources that are available both internally and in your greater community. Because as we identify needs, we have the potential to overwhelm our social workers, our navigators, community health workers, and our community resources, and potentially not actually be able to provide meaningful interventions to address those needs. So thinking about that capacity and creatively about how it is that once we identify and we ask these questions, that we are able to actually facilitate some type of meaningful intervention. Ethically, there's a lot of concern, particularly around storing sensitive social data in patients' medical records. And I think that there can be an unintended consequence in reinforcing potentially stereotypes or perpetuating biases for patients when we're putting this information in their medical chart. So it's kind of this really kind of catch-22. It's important to ask about it, and we want to make sure we're attending to these needs and we're not ignoring it, but we also want to make sure we're doing this in a thoughtful way that isn't stigmatizing patients further. And finally, I think there's already been a lot of attention recently with using the opportunity to integrate social needs screening into reimbursement opportunities as part of value-based care models. So CMS this past year put out a code to actually be screening patients and get a small reimbursement for the facility for paying attention to this activity for the screening efforts that are put in place. So I think there'll be a lot in the future regarding reimbursement. Next slide. And finally, I think this may feel sort of obvious, but I felt it was really important to sort of blatantly point it out. But we also found a lot of success when we recognize and we frame health-related social needs, screening, and interventions as a health equity activity. I think that changes the landscape in terms of partnerships, both to provide interventions and the actual resources. It provides opportunity to think about funders and other partners who share this mission and this drive, and it really helps sort of create more of that institutional buy-in because we're doing the right thing for patients and really striving to reduce the disparities in cancer care. Thank you.
Thank you so much, ladies. That was a great presentation. We so appreciate you joining us. So thank you. So our next speakers are Dr. Todd Felix and Dr. Wen-Jen Tuan. Dr. Felix is an associate professor of family and community medicine at Penn State Hershey, where he joined as faculty in 2008. His interests include evidence-based medicine and information mastery, as well as motivational interviewing, shared decision-making, and clinical reasoning. An active clinician, he currently serves as vice chair for population health and quality in the department, where he co-leads quality improvement and population-based initiatives across 14 Penn State Health academic family medicine practices. Dr. Tuan is assistant professor at the Department of Family and Community Medicine of the Penn State College of Medicine. Dr. Tuan is a clinical informatics and health services research expert in using electronic health records, multi-organizational health data, exchange frameworks, and big data analytics to improve quality and efficiency of care in the healthcare delivery system. Welcome. Thank you so much for joining us. We're excited to hear from you both.
Thank you, Desiree. Thank you to the American Cancer Society, our co-presenters, and all of those joining across the country this morning. We're happy to share over the next few minutes what we're doing here at Penn State using geomapping to identify the most vulnerable populations in our community And we'll share with you a breast cancer screening initiative we've been working on over the past 2 years. Next slide. Just as a quick disclosure, this was a partnership Catalyst grant with the American Cancer Society and a community research pilot grant at the Penn State College of Medicine. Next slide. Just show you a quick snapshot. I know you're all coming from different areas of the country, different health systems. At Penn State, we're mostly in the center part of Pennsylvania. We have 6 hospitals, several other joint ventures, and 6 institutes. We have 225 physician practices, which includes primary care and specialty. And we'll be focusing in on a small portion of that, the 14 family medicine clinics that Desiree alluded to. Next slide. So just to give you a lay of the land, this is a map we'll show you in a couple slides, this in real time. Philadelphia down in the far right corner, Pittsburgh to our west. We have most of our clinics, hospitals, and joint ventures are in the center part of the state. We span several counties up into the State College area, and different populations of people we serve have different needs, and we'll touch on that in a second. Next slide. So when we took a pause and looked at our population, breast cancer and colorectal cancer were 2 of the initiatives that we had set out on. Breast cancer being the most common cancer in women in PA. We found that PA had lower screening rates than the US average, and we were seeing inconsistencies across our own clinic locations of rates of screening. And so that really led us to look a little bit further into this. Next slide. So our goal in this project was to implement and evaluate a precision breast cancer screening and early detection navigation program in South Central PA. Our second goal was to really address the breast cancer disparities that come with varying socioeconomic challenges. Wenjian, who will speak in a second, helped to develop the clinical decision support tool that we used to identify and prioritize these women, in addition to working with our care navigators to help them achieve screening, and then ultimately taking what we have learned to inform both the practice, our department, and the health system at different level of initiatives for cancer screening and vulnerable populations. Next slide. So some of the things that previous presenter had talked about are certainly the data elements that we were looking at. And so you can see the list there, which is maybe not all inclusive, but many of the things that we looked at, including demographics, distance to imaging centers, number of missed appointments, varying comorbidities and clinical risk, as well as prior breast cancer screening. And then we'll show you in our next slide about some of the geospatial data and neighborhood statistics, which was extremely helpful in helping us prioritize where to put our efforts and care team. Next slide. So this is just a static snapshot of our GeoMap. This is the heat map of our clinic. So we'll go ahead and stop sharing and ask Wenjian to do this in real time. We were going to give you some still shots, but it's a lot cooler to see it happen in real time. So this is the state of Pennsylvania. If you're not familiar, we are right in the middle, south central part of it. And then so if you can filter down to just the central part of the state here, Wenjian. So it should look similar to the previous slide that we had showed you. And then we can look at a scatter plot of the women in our population, which there are about 20,000 who were eligible for screening over the past year, who were not screened. So all these red dots are women who have not been screened, and you can start to see it clustering there in the middle part of the state. And maybe zoom in just a little bit further, Wenjian, if you can. Okay, that's good. And then you can see we'll put in our clinics where we have our 14 family medicine primary care clinics. We care for about 110,000 patients in these 14 clinics. So you can see the green plus signs are our clinics, somewhat filtered around the patients. And then the imaging centers, I think you have those. So these are, all of these are imaging centers. And so just to kind of give you, this is where we started, which is a good place to start, but didn't quite get to the all those key characteristics that I was talking about earlier. So next we'll show you ADI, which is Area Deprivation Index, if you're familiar with that. And Wenjian, I'm going to pause here and let you kind of explain what this is and what this looks like. If you're able to. If not, I can keep going.
Yeah, sorry. The ADI is a composite index of the various socioeconomic the metrics, about 28 of index. So the number, you can see the area with a darker color means the neighborhood has suffered or experienced greater socioeconomic challenges.
Excellent. And so that was helpful for us to see. We also, another way to look at this and present this to our colleagues and health system was to do a heat map. So if you can switch over to the heat map, Wenjian. And then maybe zoom out just a little bit. I think we'll maybe zoom out. Does that help? Yeah, perfect. So you can see the heat map, certainly where we started to look, which was interesting, is the preliminary work at several of our clinic sites align with these areas of highest area deprivation. You can also see, I don't know if you have to zoom in to see this, Wenjian, but the radius around. So listening to Richard's comments about the road to recovery, as well as the other, the health lead screen looking at transportation. Obviously, this is a big one, and we were happy to see that many of these imaging centers, not all of them in our health system, we have competing health systems in the area, but we're within, is that a 2-mile radius, Wenjian? I believe it's 2 or 5 miles.
That's correct, about 2 miles.
2-mile radius. So again, there are patients that are outside of that catchment area, but still allowed us to work with these imaging centers and to find accessibility, availability of appointments, as well as our care navigators helping with these transportation needs. And then the last thing we'll show you is, I think you can do an urban zone is how we have done that. And so you consider Hershey, which is the sweetest place on earth, very rural, but we actually, if you see it'll come up here in a second, if potentially that there is a significant, based on census data, urban, so that's the brown shaded would be considered an urban zone based on census data. And so, Wenjian, was there anything else we wanted to show on this? Otherwise, we'll.
That's good.
Okay, all right. So if you can switch back to the PowerPoint. So Wenjian made that look very easy, but certainly took me by surprise when I first had seen his work. So next slide. So just to showcase just a brief blurb of what we saw with this navigation pilot. Obviously, many of the social determinants that have already been talked about or will be talked about later in the presentation became very clear in the vulnerable populations that we saw in this heat map. Disparities were seen pretty quickly with women in minority groups, Medicaid and uninsured women, those living in neighborhoods with that high ADI or multiple socioeconomic challenges, distance from imaging center, and less than one vehicle in the family or in their group. So those came out pretty clearly. You can see on this snapshot graph here that two of the things that were positively predictive for screening were if women understood their breast cancer risk, as well as if they had previous mammography. And so those two things have between a 3 and 6-fold odds ratio of improving the likelihood of screening. Next slide. And on a more personal note, I think some of our navigators might even be on the audience today. This was great work that was done. We started with 4 clinics. We have added a 5th clinic. And these were considered the highest risk women and those least likely to be screened. So 144 women entered our screening in the past year. 80 of them received mammography and many are scheduled. Those that needed diagnostic, we had 90% completed, and we had 1 early breast cancer, thankfully early breast cancer detected and treated. And then the 4 clinics that we had used saw improvements of breast cancer screening 2 to 3% at each site. And so just to highlight that the work that's being done to screen for social determinants of health certainly is leading to efforts to help navigate these folks through the health system and ultimately, prevent disease and promote health. Next slide. So thank you for your attention. Obviously, put Hershey on your map. Our motto is where fun meets chocolate. So if you haven't been here, we welcome you anytime. So thank you.
Thank you so much, Dr. Felix and Dr. Tuan. That was a wonderful presentation. Appreciate you both taking the time. So thank you. Our final speaker will be Natalie Penniman. Natalie currently manages psychosocial care for surgical and solid tumor oncology patients at The Ohio State University, the James Cancer Hospital. Since 2003, she has been focused on improving psychosocial care and health disparities in healthcare. Hi there, Natalie. Thank you so much for joining us.
Hello, everyone. I'm here to talk to you about social determinants of health and how Ohio State is kind of tackling this. Next slide. Earlier in my career, I worked with children in an oncology setting. Since then, I've done emergency care and trauma and cardiology, but for the last 12 years or so, I've been working with adults in oncology. And what I've seen in every population that I've worked with is that we have seen health equity issues. Now, according to the CDC, health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, and access to treatment. Next slide. SDOH is not a new concept. However, how it's being organized now, how the domains are being organized, and the education efforts that are being put forth is relatively new. As was covered in some of our previous presentations, there are several domains within social determinants of health: alcohol use, depression, financial resources, food insecurity, housing stability, intimate partner violence, physical activity, social connections, stress, tobacco use, and transportation needs. What we're seeing is that there's a higher rate of incidence within these domains with oncology patients as compared to the general population. Next slide. At the James, we have well over 400 beds with a dedicated oncology emergency department system, multiple clinics around the city. And with being such a large institution, we had challenges of how do we effectively assess and intervene with the social determinants of health with the patients that we're seeing. The challenges that we came across was who's responsible for assessing the patient for each of the domains? How do we ensure each patient is assessed for all of the domains? How often do we assess? How often does it need to be completed with patients? How do we communicate the assessments in a multidisciplinary setting? How do we establish a plan with the patient and their support system to maximize success for the interventions that we do and related to the domain that we're trying to address? And how do we educate our colleagues on the importance and the impact of social determinants of health on the overall care of the patient? Next slide. This is what we came up with. First, we had to figure out who does the work and who needs to be aware of the work. Because with multiple disciplines in charge of certain aspects, so to speak, of the patient care, it doesn't make sense for everyone to try to do this particular aspect of the patient care. So we also had to figure out, once we figured out who had to do the work and who had to be aware, focusing on the work part, who does the work with the different backgrounds that are paying attention to the patient. So we had to clearly delineate who assesses for what domains at what time during the journey of the patient's care. And that's between inpatient and ambulatory. And we had to break that down between social work, nursing, and our nurse case managers. What we did was base that upon the clinical background of the care provider and the access to the patient at what time during the journey. We broke that down with alcohol use, with the nurse and the social worker. Depression was broken down between the nurse, social worker, and the case manager, depending on the setting that the patient was in. For financial resource and strain, that was the social worker. Food insecurity and housing stability was also social work. Intimate partner violence was the nurse and the social worker. Physical activity was the nurse and the nurse case manager. Social connections was the social worker. Stress was social worker and the nurse case manager. Tobacco use was the nurse, and transportation needs was the social worker. Being able to establish who was responsible for what made sure that nothing fell into, nothing was missed. It gave responsibility and communication flows between each of the domains, between all of the disciplines. We ended up setting a timeline of a 60-day minimum to make sure that each patient was assessed within 60 days throughout their journey. So no matter how long that they're with us, that assessment will be completed, because things change, and we want to make sure that we address the changes if and when they are detected. Technology enhancements with our EHR to make our documentation and communication easier and more visually accessible within SDOH domains. I think a previous presenter had shown Epic, which we also use. We use something similar, and we make sure that it is visually accessible and is talked about in rounds with our patients and our providers of what is going to be the thing that's going to affect the patient the most. We started classes and seminars with residents and within orientation courses. We also developed a we already had a relationship, but we maximized that relationship with our colleges at Ohio State. So the College of Medicine, College of Nursing, OTPT, all of the disciplines, so that we're getting that message about the importance of SDOH before they even come to work at Ohio State. We also increased our partnerships with community agencies, and I'll talk more about that in a second. Next slide. We established and encouraged the communication practices in relation to the care of the patients. And we also took a very unique approach in making sure that patients are more involved, not just in the assessment, but how to carry out a plan that is the most effective for them for their journey. Next slide. This is a lot of work. And so we're pretty blessed to have close to 70 social workers in 24-hour coverage with our inpatient and ambulatory areas. We have our nurse case managers, our physician champions, our data analytics, and we're excellent community partners with Central Ohio, as well as expanding out. Our patients are coming from further and further away. Next slide. As we are doing the assessments and having that information in our electronic system, we needed to understand what we're learning. So the data that comes from the SDOH assessments are helping to guide our future. We're tracking our outcomes as we're doing interventions that related to what we're discovering from the assessments. We're tracking how effective was the intervention. Did it have a positive outcome? Did it have any outcome? Was there a resource available? We can see where our patients reside, and we're pulling that data from zip codes to see what interventions are there. Is there something that needs to be created in this particular area? And focusing more on the preventive health in relation to what we're discovering here. With the more data in the area, the financial shift can be made from reactive to preventive in healthcare initiatives. The first impact being the cost of the emergency room care. Next slide. I think I covered some of this. I apologize. Next slide. I didn't know I had that in there twice. Okay, so just to recap, as we're looking at our community agencies, we're looking at areas that we're missing. We had the area in Columbus called the Near East Side that we had a lot of SDOH issues that we had identified, but we didn't have community resources to address the population in this particular area. And Ohio State is putting some investment efforts into this particular community because we realize that preventive care is needed. So I'll stop there and give it back over.
Thank you so much, Natalie. That was wonderful. We appreciate you joining us. So thank you. So it is now my pleasure to introduce our panel moderator, Heather Lewandowski. Heather is a Senior Director of Health-Related Social Need Interventions for the American Cancer Society. In this role, Heather works closely with cancer centers from across the United States to create and improve health-related social needs screening and referral workflows and build community resource networks. She is also responsible for the creation of the comprehensive HRSN workflow development tool and tends to support to various other society initiatives focused on understanding and addressing social determinants of health. Hi there, Heather. Thank you so much for joining us and for being the moderator of our panel discussion.
Thank you so much for that wonderful introduction. So excited to be with you all today and to be able to moderate some conversation with our wonderful panelists. I want to first circle back on a few direct questions that have come in related to a few of the presentations we had. And I'm wondering if I could first start with Becky and Dr. Safat from Sidney Kimmel. Becky and Dr. Safat, whomever wants to come off of mute can answer these, but we did have a question come in asking who is responsible for using your SDOH screening tool within your clinics, and at what point in the screening and diagnosis continuum is it used?
Yeah, we do a multi-team effort in trying to get as many of our patients screened as possible. We're screening about 64% of our patients in active treatment right now. And so it is a team effort. We have our oncology navigators who are trying to do the screening as part of their initial touch point with patients. Sometimes that doesn't always happen, because we're really integrating this into sort of routine workflow and routine conversations with patients to make it kind of natural and part of standard care. If social workers then see that a patient that they're following or they're involved with hasn't also kind of historically been screened, they are also making the effort to screen those patients in all 8 domains at any point of kind of that interaction. So, I think there's a lot of opportunity, especially for rescreening. Right now, our goal is to be screening patients in active treatment once a year. And so certainly, as we know, HRSNs and these risk factors evolve over time. So we're really just striving to at least get it done once, and then hopefully the opportunity there is to rescreen as we move forward.
Thanks for providing that clarity. We had a follow-up question to that, which is also asking, Becky, if you all have explored or are utilizing any type of reimbursement for SQH screening services, including G0136 or any of those similar codes.
Yeah, we unfortunately haven't gotten that far yet. It's certainly an opportunity that we're talking about and just getting on the surface of exploring. My understanding, though, is that that code can be used once every 6 months on a single patient. I think it has to be linked with a physician visit, so it needs to be kind of occurring simultaneously, although a physician or provider doesn't necessarily have to be the one asking the questions, but it does need to be linked with a visit. And it can occur in sort of multiple settings. It could be primary care, or it can be in any kind of health management sort of follow-up or specialty care as well. So more to come on that. We're excited to learn a little bit more.
Thank you. I'll pose that question to the larger panel if I can, related to reimbursement. Are any of you using any types of codes to bill for your social determinant of health screening practices?
We are not. We include that in the care of our patient, and we didn't want to create another burden when we're assessing for the social determinants of health to create a bill for that. So no, we're not doing that.
Yeah, and we're currently doing an inpatient at Penn State, just starting to roll it out to all of our outpatient practices. I think the plan was to use the G code, but to Natalie's point, we've got some, coming to consensus on that. But that would be, it's not a huge reimbursement, but it does, validate the work that people are doing.
Yeah, thank you for that. I know that reimbursement within the field of social determinants of health is so emerging right now. I think we're all kind of learning together, especially with the CMS passing of new codes here in 2024. This is such a new frontier for us. Dr. Felix, I wanted to circle back with you. We had a few direct questions for your work. One of them is asking if the map is national or just specific to Pennsylvania, and who might be able to have access to it.
I will be happy to answer this question. The interactive map was developed using a geomapping tool, which is called ArcGIS. We are able to access the ArcGIS through the Penn State College of Medicine. There could be some costs if you don't have license. There are other great tools if you want to use it for geomapping purposes besides ArcGIS. And in our presentation, we only present Pennsylvania, but of course, you can create your own maps for your states and neighborhood as well.
Thank you. Follow-up question to your presentation as well is, how did you determine the number of women eligible for screening who did not get screened? And did this include undocumented individuals or those not within a health system?
Yeah, great question. So our EMR identifies women who are overdue for screening, meaning not having a mammogram within the past 24 months. And those patients were attributed to a primary care practice. So many of them have a variety of payers, Medicaid, Medicare, and commercial insurance. So that's the list we started with, and used that list to perform our analysis and heat map. For undocumented, it's a great question. We collaborate currently with our Cancer Institute. We have an Office for Cancer Health Equity, and they're doing some outreach in those communities to help do some preliminary screening as well as link patients to primary care practices. But I wouldn't say that we have totally solved that challenge in our community.
Thank you. One final direct question. This one is for Natalie, and then we'll move on to some more general panel questions. Natalie, there's a question in the chat asking, once the challenges are identified, what is the workflow for intervention?
Good question. Depends on the challenge. So okay, so when I was speaking of challenges, I was speaking of the challenges of trying to figure out who does what and how we're going to operationalize it. So I'm not sure if you're speaking about that or if you're speaking about when we identify something within the SCOH that needs an intervention. So I'll briefly talk about both and hopefully I'll cover the answer. So in identifying the challenges, you know, like I said, we have about 460 so inpatient beds and then clinics all over. So it was trying to get everybody to go into the same direction, which is, I'm sure everybody on the panel knows, can be hard to do. Getting the stakeholders, really sitting down and doing a DMAIC process of how we're going to address what, how do we define the issue, how do we do the measurements, and it really was a separate approach in each clinic because there's different disciplines that are available in each clinic, so it had to be individualized to the location. So that's how we kind of address the challenges. In defining that, we realized that people generally speaking, don't understand why we're doing that. So we had to take the education back, and we decided to start back with the colleges so that people, you know, as folks are joining us in the field, as new grads are joining us in the field, they are understanding why it's important. And using the social determinants of health, as social workers, we want to have the conversations of we're finding this and we understand this and we want everybody, and that wasn't working. So we had to use, you know, I use it as Rosetta Stone. How do I change what I'm saying to the language of the people who are listening to me? So if I'm talking to business people of why I need money, why I need investments, why I need this, then I needed to change my language so that they can hear what I'm saying. So it really was resource based. How much money can I spend? How much money can I save? How can I put this into a spreadsheet and income and budget so that you're hearing what I'm saying? I'm saying the same thing, just in your language. So that was the challenges, how we addressed it. Social determinants of health, once we identified it, was some of the things we're identifying, there weren't resources available or limited resources available to address what we're finding. So it's not an easy fix, but if we're finding similar to the, I guess, the geo mapping which I was fascinated by, you guys. Oh my God, I have so many questions. I loved it. But if I'm finding that these 5 zip codes are having an increased number of food insecurity or transportation, and there's not a resource there to address this, what are we, Ohio State, going to do about that, if anything? And so it triggered additional conversations. And that's why I kind of brought up like the Near East side of Columbus, because we were finding like this area right here, we've got to pay attention to. And from a business perspective, this area right here is costing us a lot of money. So if I'm going into meetings with the business folks, I was like, do you want to spend the money more, or do you want to save money? Well, saving money seemed to get people's attention. So that's where it's like, okay, we got to look at this and we have to have this investment and we have to have these conversations. So did it take a few years? Yes. Has there been some changes there? Yes. Have we seen the impact? Not yet, because it literally, some of these things just opened, I want to say like 2 months ago. So ask me in a year if we're seeing some of the impact from the investments and things that we've done. But it really is a concentrated effort. There's a lot of conversations. We need to get these, you know, agencies, we need to get relationships and this and this. You need to concentrate it on what makes the most sense. You can't just partner with everybody. I don't need you as a partner if you're not addressing where my concerns are. So that's where it really, where it kind of starts this way and kind of goes in. Like I need to concentrate it on what's giving me the biggest bang for my buck. And that's where we are right now. So hopefully that answered the question. If not, type something else in the chat and I can answer it better, I guess. I'm sorry.
No, that was fantastic. Thank you, Natalie. Question to all panelists, as we think about implementing social determinant of health screening and referral workflows, what ethical considerations should we keep in mind, and how have you all put thought to those?
I think is it Becky, I believe. I think she kind of spoke to that in her presentation and really hit it. There's the ethics of, is there going to be biases that we create? We want to make sure everybody is aware, but I can't control what your brain does with that awareness. And how does that impact your reaction and your intervention and your relationship with the patient and their support system? So we've increased implicit bias training, and trying to think about how to counteract things that we anticipate, and then as we're going down this journey, things we didn't anticipate, and making sure that we're looking at that and addressing that from a global perspective. We're really blessed to have some amazing physician champions here. There's no way we could do this without our partners here. And so with that, we've taken that implicit bias, and where it was optional, it's no longer optional. You have to be able to be aware of what's going on internally with yourself and how to do that. We can't control, our community agencies, but we really have some very open and honest dialogue that we let people know that this is a safe space. Like, if you're from our colleague to colleague, this is a safe space to have those conversations. And that's how we address that. And then we learn so much, of course, from our patients of what we need to address with them. And as we learn, we grow and we adapt.
I think Becky, did you want to? I was going to say that Becky and I have talked a lot about this, actually. And I think, Heather, you've been involved in these conversations as well, where we say why we can't screen for something if we don't have the resources to do something about it. And so at Sidney Kimmel, we do what we can as an institution, but we also rely a lot on the social sector and the nonprofit organizations. But Becky, please.
No, that segues. And I think there's a lot of, we work in these siloed systems of our social service sector and our healthcare systems. And so there's been propositions around what if we could actually create like a connectivity between them with like one EHR, for example, and see where patients are getting their meals on wheels and having that help them kind of navigate that all together. And so in some ways that sounds like the best idea ever, but it also brings concerns. Again, the more we're integrating more of this social data into someone's medical chart, it has the potential to kind of raise and perpetuate biases on those patients. And so it's really tricky to sort of move forward with that and sort of make that assumption that that's kind of the best way, yes, kind of logistically, coordination wise, but there are always some unintended consequences that come with that.
I think those are really important reflections. There was a question that was posed a little bit ago in the chat that I'll kind of pose to the group because it's on the same kind of breath as what we're talking about. And the question was, do you feel that asking patients the same SDOH screening questions in so many settings is burdensome, especially if there are not many resources to help with an identified need such as housing?
Absolutely. And especially, housing is one of the trickier ones there. And I think, it depends on also the specific cancer center and sort of what their breadth of supportive care services and their programming looks like in terms of how able you are to respond. And so are you really kind of like a one small community setting where you have one social worker and they're responding to all of these and triaging and prioritizing kind of patient needs every day, including all the SDOH needs? Like, that looks very different than a more kind of robust sort of supportive care program. And certainly the community resources can be very limited in certain areas. But I think to Natalie's point earlier, we need to have some data as a starting point to explain that, hey, for our cancer population, this is our highest need. This is, we're seeing 15% of our cancer population who can't get here, who are reporting some type of transportation difficulty, and sort of knowing, what is it that, which of those domains are where we need to start and focus on. And then the greatest success we've had is really building with other kind of community resources and nonprofit organizations who are specifically interested and share a mission and wanting to reduce health disparities for cancer patients. And if we can come with some data that's concrete and say, this is really what we're seeing among our population in these specific areas, that's, I think, the first step to then get some more targeted resources.
Yeah, and we piloted, as I think Becky, you commented on the tools earlier, we piloted the prepare screening form, which is I think 20 or 21 questions. And so that discussion happened at a leadership level here about, burdening, over questioning patients. And, I don't think that was necessarily, we had some pushback, but most of the time it was more of, what are we going to do with all of this information? And I think that's similar to our previous discussion, realizing the bandwidth of a care team, including our lovely social workers and the care navigators. The other thing that came up as we discussed this is, screening them once a year or twice a year, things can change in a month for these folks. And so we were struggling with how do we do that well? Like just every January is not going to be the time that social determinants comes up. And so I think that's the discussion you should be having with your health system.
Agree. We were doing it when we first started this, we did this every touch. So every time a patient was inpatient, every time they had a clinic appointment, every time they came to the ED. And what we found was some frustration with why are you asking me the same thing over and over? I was just here Tuesday. So we went from that to every 90 days. And then what we found was we were missing, we had some of our patients in a crisis situation that we feel like we could have avoided if we'd have just hit this, a couple of weeks before. So I think last month or the month before, we just switched to 60 days and we modified our assessment from if we haven't seen them in over 60 days, we do a full, I won't get into all that. We'll do a full assessment. But if not, then we have kind of a condensed version to make sure we're still hitting some of the key areas, but we're not doing the whole thing. We also trained our staff on how to ask the question. So it's not that I'm, asking you directly. So, what about food insecurity? I saw last time you were here that, XYZ was going on, so that the patient hears, I'm reading your chart, I'm hearing you. I just want to make sure that this is still the same. And if it is, great. If it's not, let's talk about it. And that just change of approach in the question has done wonders in terms of patients understanding that we're here and we don't want you to have to go through the same thing over and over. But if there is something going on, we want to make sure we catch it right now. So that has been a work in progress of kind of hitting that sweet spot of getting the information and providing the interventions.
Thank you. Lots of questions coming in about how you all are partnering with your community, with other community agencies, public health, different entities to help support individuals with social determinants of health. I'll start with Becky and Dr. Safat. Can you share some of the types of agencies and partnerships that you've been able to form?
I can start. So one of the most impactful partnerships we have is with a local nonprofit called Legacy of Hope. And they are committed to addressing food insecurity among Philadelphian cancer patients. And so using this tool, it really does help us identify those patients. And they have a really beautiful partnership with the Philadelphia Police Department. And so the Philadelphia Police Department will actually deliver $200 worth of groceries to our patients who are in treatment. And so we help facilitate those referrals. And Legacy of Hope had in the past year provided us over $60,000 in financial support through food delivery, as well as different kind of pro bono relationships they have with contractors and people who came in and helped fix utility kind of needs and issues and housing home repairs for patients where that was a big stressor for them as they were going through cancer treatment, finding refrigerators that were donated. So really kind of as we identify an issue, we throw the question out to them and many of those other partners and work together to try and find a solution. But we never really know what those issues are unless we engage with patients about that. And so, yes, we can't necessarily always do something about it, but sometimes we can. And it feels really great when we can make that difference. The other thing I'll add that has been really helpful is we do an annual report every year for our Division of Supportive Oncology Care that we share with our leadership and sort of nationally, where we highlight a lot of these community organizations and we put down, exactly how many patients and families have been touched. Did they receive, gift cards or something, gifts in the holidays? And we really have it all compiled together with that big financial impact. And so last year we helped patients with over $1 million in addressing these types of needs, these quality of life, these concrete needs through these various partnerships that we had with just community organizations.
Wonderful. Dr. Felix, Wenjan, anything to add from your organization and community organizations that you've been able to partner with?
This is where, I was thinking about this as now I was talking, it takes a large team. And so I don't have our social worker care navigators on, but they do a lion's share of the efforts. I'll just touch on, I know so we presented on breast cancer screening as our specific focus today. So what's neat to see is there are warm handoffs between, our role in primary care, our breast center, our cancer institute. We've navigated some work with the Department of Health in Pennsylvania, and then have many different spokes of I think touch points in collaboration with our mass transportation and busing, as well as financial assistance for utilities and others. And so I know that there are a lot of touch points. My suggestion is it takes a large team to do this well. And so appreciate the work that everyone's doing. Wenjan, do you have anything else on that?
Yeah, I think Dr. Felix has explained everything pretty well. So one thing I've been hearing a lot is really about how we can collect the data, especially relating to the social need of our patients. Sometimes patients may not feel comfortable to tell us everything at all. So in our program, we started what we call a precision navigation. That means we have a data system running behind the scene, maybe collecting information, may not from the patient, but we look into the geographic statistics or other things, put out into our programs. I mean, hopefully we can develop some kind of predictive modeling. So when a patient come into the clinics, we will probably have some kind of information or guessing from our AI program to know if the patient may have experiences or challenging about transportation or anything else. So our social workers or navigators can provide assistance instead of just asking long questions.
Thank you. And Natalie, I'll pose this question to you too to close out this question. What specific partnerships or agencies has your health system been able to partner with in addressing needs?
We have several, but the one that just jumps out to me, we have a program called Hope Hollow here, a nonprofit agency. It was started by a husband and wife, and the wife was a cancer survivor. And when I tell you, these two are the most dynamic people I've ever met in my life. I love them to death. But they absolutely have made it their mission to help as many cancer patients as possible. And in partnering with them, we kind of had another partnership, I guess, with stakeholders around the state of Ohio, restaurant owners, golf club, folks where money can be brought in, so to speak, and being able to have that money brought in through Hope Hollow and funnel it into whether it's food insecurity, whether it's housing insecurity, or just I need radiation for these 6 weeks and I live 3 hours away, so I don't have a housing issue. I just have it for this time period. You know, things of that nature. And they have been phenomenal in thinking outside of the box, and being able to work with us and our administration. And they've helped so many, and it's helped us think outside of a box. As an institution, we think a certain way, because that's just how hospitals are. And when you bring in some folks, it's like, well, why can't we do this? And when they pose that question, it's like, well, why can't we? You know, we should be able to do this. And because of them, we've actually branched out into other areas. So our partnership with them just goes beyond what they can do for our patients, but it really helps us think of other ways to do things besides just helping the SDOH needs that we identify. So I want to highlight them. They're amazing to work with.
Thank you. A follow-up question to this is, what workflows or processes do you all have in place to measure the impact of partnerships with community agencies or referrals that you all are making for individuals to help support them with social determinant of health needs?
We track our outcomes. When a patient identifies whatever it is, I'll stick with food insecurity because that's what's on my mind at the moment. When that gets identified, and we put that into our medical record, what did we do? Did we make a referral to Mid-Ohio Food Bank? Did we, you know, if they're not from Mid-Ohio, whatever their county may be. And then we track it. How long does that referral take? How long did it take for them to connect with this particular agency? It's a little more challenging when some of the places have to be a self-referral. Like we can't make the referral for the patient. They have to do the self-referral, but that's okay. We're working around that. And then, you know, we want to track the time frames, and we want to track the impact. We want to track how long they were connected with this particular agency. So when we put in the intervention, let's say we put it in today, July 25th, they'll have follow-up appointments. They'll come back to the hospital. You know, we're going to kind of touch that patient again throughout the journey. And then we check, you know, how long did this take? Do we have confirmation through whatever agency it was that, hey, Mr. Smith did check in for this particular referral? And then behind the scenes, we use Tableau to kind of track our measurements of, did this intervention have the impact that we wanted it to have? Then on a global scale, I can pull, you know, patients from this area, patients with these comorbidities, patients on this particular service, patients who worked with this particular social worker. You know, maybe it's a person issue. Are we not explaining this well to the patient? So that's training for our staff. Is it, you know, that this agency wasn't able to provide it? We need to find another agency. We're referring too many people. So we identify, did it work? And if it didn't, where did it fall? And where do we need to address the issue? So yes, we track our outcomes so that we can get better every time.
And I think the process that Natalie's describing really highlights the opportunity to leverage technology and our electronic health records to do some of this for us. But the challenges like Epic and these electronic health records were really built to be billable systems, right? They were built to bill for services. And so not to track care coordination activities. And so the challenge is we may have this process of integrating screening in, like that's the first step. Then you're trying to connect it with maybe a flow sheet or some type of documentation. Maybe it's just in a narrative Word document where your social worker or community health worker or navigator has put in, yes, I did respond to this. So you have to connect those dots. Then you have to connect it to an actual resource, and did the resource follow through, which also isn't in the record, and then an outcome. So it's really complicated to really kind of showcase the whole downstream impact of what screening can do and the impact that it really has on patient care and the potential cost savings. But I think if we can really leverage our information technology folks, I have a lot of friends on our Epic team who I use to try and figure and solve this puzzle, because it's not an easy challenge to solve.
Yeah, we have spent almost a year and a half to learn the systems and get the data and somehow put everything together, create a risk scores for patients. So then we provide the information to our care navigators that have a larger from our social workers, and they will look into the list and to identify the patient's need and any issue from our analysis, our AI predictive models. And then what happened is it kind of challenge for them to help patient, or when they talk to patient, they may make a referral to right during their conversations. Somehow maybe they can make a referral, maybe they can set up appointment for our patient. However, the access to the screening centers or the spots could be a little bit challenging. That's where we have some experience delay. And right now we're hoping we can learn to be more about, okay, now we know our patients and know their need, but sometimes the patient may still refuse to go to be screened. So we want to have better understanding to build a better predictive models to identify patients who may have additional challenges. So again, it's take us a long time or long way to just build a predictive models. And now we're moving back to see how we can make sure the workflow can go through in a streamlined way.
Thank you. I'm wondering how you all have seen the digital divide impact individuals' ability to access screening or prevention services, and also individuals' ability to impact some of the resources that we attempt to refer them to.
Yes.
Yes, it's a problem.
Yes, it's there. Yes, it's a problem. We try, we don't have a systematic way yet. That's one we haven't tackled. I can tell you COVID brought a lot of people forward pretty quickly, in terms of learning technology that they hadn't learned before. And so it's a blessing from COVID. I don't know if you want to call it that. So I would say it's not as bad as it was prior to 2020. However, we do take that time to educate when we get folks that aren't as familiar or don't want to access things through their phone or my chart or anything like that, to try to explain it. And at the end of the day, if they say no, if I'm not doing it, we respect it. But we definitely see that as a challenge, and as we move more forward, I think it will become less of a challenge, not more of one, because more people are like, all right, fine, I'll do it, as is, and they, kind of join. But like I said, I think 2020 made it not as bad as an issue as it used to be. So we'll get there.
I work a lot with immigrant and refugee populations, and this is a huge issue in that population. Even if I could get them to download my chart, it's in English, and they're not able to do the screenings, let alone pick up the phone and be connected to a nonprofit sector. So agree with Natalie. Yes, it is a huge problem.
Yeah, and I don't know when, Jan, was that part of our, was that in our data set? I'm trying to think through, because we have, part of our process was, again, how many touch points do you try to reach patients, whether that's via the EMR, via phone call, text messaging, or other modality. And so you definitely see that in some of those spots that we had kind of hotspotted, so to speak, that was a major challenge in contacting these patients, which, you go back to the ethics of it all. Just these are the people in highest risk and highest demand, and yet we can't reach them. And so I don't know that we've actually looked at how much that's impacted us. Jan, do you have any info on that?
No, that will be our next stage, just look into the impact analysis.
We'll come back next year.
Yes.
We look forward to hearing from you next year with an update on this very important question. There's another important question that came through the chat that I want to pose to the group. And this person is asking, do you think that patients' embarrassment or hesitancy to ask for assistance is a significant barrier?
Absolutely. And I think patients, we have to remember, some patients are coming in with a lot of mistrust of healthcare systems, and they're coming in with a lot of trauma that's being re-triggered when they enter into the cancer center, into the healthcare system. And so asking them about sort of their vulnerabilities and their risk can feel, really uncomfortable for them. And I think also patients worry it could impact their care. It could impact their treatment options. If you have a patient who is potentially going to get a CAR T treatment, and and that graphic I showed where there's the wheel and there's a lot of red in there, that there's all these social risk factors. What might their physician think about their ability to get through that treatment and be successful and have a good outcome? And will they potentially be limited? So I think those are really legitimate fears that patients, whether consciously or unconsciously, have when we have these kind of conversations. I think the best we can do is to try and establish trust and try and establish rapport with our patients and build that connection, and let them know that this is just standard practice to kind of be asking about these questions. And it's because we care. It's because we care about what are the other stressors that are going on in their life. And if there's something that we can do to minimize some of those stressors, we want to be able to help them with that, whether it's something kind of smaller or something quite large. And so that's why a little bit in our workflow with our screening process, there's a little bit of clinical flexibility in terms of when patients are screened. And so we kind of have some, try and have the navigator do the screening during the first encounter. Well, if that doesn't feel appropriate for them because this patient is coming really guarded, then it's not going to be a very successful conversation. And so we allow there to be some fluency in terms of really having that dialogue and when it occurs, because it has to kind of occur in an organic way as well. And I hope that those efforts can help minimize some of their fears and apprehension.
Yeah, I agree. This is something that I think myself and others are still trying to understand. So like I said earlier, we rolled out the Prepare screening tool. I can't remember off the top of my head the percentage that's screened positive, maybe 20%. It probably varies depending across your region, but of those, only a very, very small percentage, like 1, 2, 3%, said that they wanted additional help. And so I think that's what Becky's probably getting at, is like, they don't, what does this mean to get help? And there may be an embarrassment factor, there may be suspicion, there may be other factors involved, but I don't know what to do with that information when it comes on my patients, because we get copied on the screen positive. So it's a very good question. I don't know if anyone has totally figured this out, but I expect that it will come out as we start to normalize this more across health systems.
Yeah, and I want to echo something that Natalie talked about earlier, which was just speaking to the importance of implicit bias and cultural humility as we approach patients and screen them, and how important it is to be conversational in explaining our intent and helping them to understand our desire to both understand their needs and also to help support them in connecting with resources. Another, I think, excellent point that's coming through in the chat is somebody commenting on health literacy and the impact that health literacy can have on individuals being able to access care or clinical outcomes. I'm wondering if anyone can speak on that, the impacts you've seen from health literacy with different individuals in your health system.
In terms of screening, this is why I think it's really important to know and understand the tool that you're using and that it's validated. And so, how are those questions worded for patients? Some institutions do various ways that they screen. They might not have it be a conversation. They might have it be a push out through their My Chart so that patients are self-reporting, or maybe the patient gets a tablet when they walk into the cancer center and they need to be able to read in response. And then there's a follow-up conversation, maybe with a team member if there's high risk. And so first we want to make sure that the tools that we're using are validated and that there's certainly consideration of health literacy for patients if they're kind of answering those directly.
I know we have tried at Penn State to look at the populations we serve, translate our screening tools into common languages used. We've also, both our care navigators, as well as in each of our clinics, at least for the breast cancer screen use language line. So we make sure that we are translating into preferred language for the patients as we're talking to them, either in clinic or on the phone.
I've seen a couple comments in the chat, and I want to ask a specific follow-up question based on those related to the need and the importance of navigation services. So not just screening and connecting an individual with a resource, but also having navigation services to help support them throughout their cancer journey. Wondering if you all could speak to how patient navigation services can be optimized when we look at screening individuals for social determinants of health and supporting them.
For us, we've had our navigation services, I want to say a few years now. Granny can't remember, but we've had we've had our navigation services for a while. And what we are finding is that in some areas it's a perfectly working machine within the clinic settings, and we have some inpatient as well. And where that connection is internal navigation, how to navigate the internal systems of Ohio State, because it's really hard to know what department do I go, how do I ask, where does this happen? And then also navigation services for external. So we kind of have it in a divided sense, so to speak, of, where do you need to go, and when the navigators can work with each other. Oh, that's an internal thing for Ohio State, or that's external for an outside agency. And then in some areas it's a little more gray, and we need to work on how to define the navigation service in terms of what does the navigator do versus the social worker versus the nurse case manager versus the clinic nurse, because it can be murky and add confusion to the patient, which is not what we want to do. And so I think, I can't speak for other institutions. I think for us at Ohio State, this is still a work in progress, and it's still an area of opportunity. It's an area of opportunity to help utilize that service better than what we're currently doing.
Yeah, similar. The model, I think, is so variant on, each cancer center. I think a little more my institution, the navigators are really helping more upfront with kind of getting patients in the door, getting them all the sort of pre-screenings and all of the blood work and sort of everything they need to kind of get set up for care. And they're following longitudinally, but sometimes it's a little bit more of navigating the health system internally, because it's a big, large academic medical center. And so in our model, and our social workers are more responsible for addressing the financial toxicity and some of the kind of community more navigation with resources. But again, that model really, it's so variant based on the resources and funding and just design of each cancer center about what that looks like.
We're getting some great follow-up questions in the chat, and I want to make sure I touch on those in the 7 or so minutes that we have left together. One of those questions I'll direct at Dr. Safat, asking specifically a little bit, if you can share a little bit more about how immigration status can affect access to cancer care services.
This is a tough one. So I think one of the reasons it is tough is people don't want to disclose their immigrant status, because it has to do with whether or not they have insurance, whether or not they're in the States legally, quote unquote. And so it's a huge barrier to care. I work for the Community Outreach and Engagement Center, and so we have a mobile screening van that actually accepts uninsured patients. We do not ask people's documentation status because we realize that's a huge barrier, and we're able to give care to anyone who needs it from philanthropic funds. But that's a very special case. I'm not sure how it would work for someone who was uninsured and undocumented that just showed up at the clinic at a static site. So I know it's a huge barrier to care. We, as at the community outreach and engagement team, we have our workarounds. But I don't really have a good answer. I'm sorry.
A question for the full group is asking how you use specific metrics to measure cost justification or savings from your programs.
For me, I'm the nerd of my department. I love I love getting into the numbers and, what does this, what does this cost? What is the salary of a social worker versus the cost savings of that social worker's interventions with the patients? And how can I justify an additional FTE versus the anticipated impact that social worker would have with the patients that they would touch. And so when I first joined our department, we had 23 social workers and we were Monday through Friday business hours. 12 years later, we're 70 and we're 24/7. Because we're able to sit down and put on paper and show, if you give me this amount for, salary and benefits of an FTE, but I'm able to save, 2-3 length of stay, days within a length of stay, or prevented this amount of admissions from the emergency department that were unnecessary, even prevent emergency visits in the first place that they don't even need to come, then I can easily justify this salary versus, what we're doing. And over time, administration has seen that and supported that and has allowed us to grow in the way that we have grown. So it definitely has, has that impact. I wouldn't be able to do this by myself. I have a wonderful data team. If I'm asking for certain numbers and they're like, "Oh, Natalie, what are you doing now?" I'm like, "Okay, this is what I need and why I need it." So they've been extremely helpful. But before, it was literally me in an Excel spreadsheet on a Friday afternoon having a great time. So it definitely has worked out, and continue to see that that impact and that growth into using the data to do that justification. So
Yeah, that's a good question. I mean, we used our project as a kind of proof of concept with 2 part-time navigators, social work navigators, and so that information we took to our Department of Health as we look to screen for other cancers, and so looking at not only FT support from our health system, but also partnerships with our Department of Health, and that's been well received.
Yeah, I did a research study looking at SDOH risk, and the outcome variables we looked at were ED visits, inpatient admissions, and missed cancer appointments, and found, kind of not surprisingly, but the folks who had higher social determinant of health risk, particularly had more admissions, which isn't too shocking. But did support, obviously, that there's an impact and aligns with the literature, just how pervasive some of these social risk factors can be in impacting cancer care and potentially acute care utilization. The other thing we did is in 2018, we piloted and have grown a transportation program where we're providing Lyft and Uber services, so ride share services for patients who elicit high transportation barriers. And this was a very labor-intensive process, but we took 1 month of data and we looked at the amount that we spend on Uber and Lyft rides, that total cost, and we looked at the any patient who their associated visits and the reimbursement per visit. So whether it was a chemo infusion or a radiation treatment, perhaps even the whole month they had radiation treatment and got a ride. And for both departments, medical oncology and radiation oncology, we found that the spend on the Uber and Lyft was about 2% of the total cost of reimbursement of what we got. So it was sort of a no-brainer that if we are helping patients comply and get here, that cost of that chemo drug and what we're getting reimbursed or that radiation treatment was well worth the $25 Uber ride. That was sort of our beginning stages of trying to start to provide some rideshare rides for patients, and have really actually grown that transportation program. Now we give out 15,000 rides a year to our 6 treatment sites through rideshare programs. So really difficult, though, to continue to show that impact. Rideshare has also increased a lot in price. So I'm not quite sure that same analysis today would show the same spend, but I'm not going to say that to our business folks. We're going to keep doing what we're doing because it's the right thing to do. And it really does. Transportation, I think, is documented, and for our population is the largest barrier for cancer patients.
Thank you so much. And I want to extend a huge thank you to all of our panelists for joining us today and for sharing your insights, for answering the wonderful audience questions. Thank you so much to our audience for being so interactive and really making us think and provide thoughtful answers. I'm so excited to have been able to share this time with you and for all that we've learned from you today.
Thank you so much, Heather, and our panel members for a great discussion. That was awesome. We all learned so much. So let's take a moment for our final poll question. In your experience, what are the greatest health-related social needs in relation to cancer? So you'll have a few seconds there to answer that. And as you answer that, we're going to get ready to introduce our final speaker today, and she comes from the American Cancer Society. It is my honor to welcome a wonderful colleague and friend. Maria Cabrera is here to share more information about the many resources available on cancer.org. Hi there, Maria.
Hi, good morning, everyone. You're good. So I know it's been a long hour and 45 minutes, so I hope you guys will bear with me because I have some really good information to share. One thing that was not on my presentation that as I was listening to the conversation, I felt that it was very important to highlight today was our Find Help partnership that we have. Find Help, as many of you probably know, is a social care network that provides a lot of information in terms of social need programs for patients. The American Cancer Society partnered with Find Help, and we actually will share the website, the link to that with you all, which is cancer.findhelp.com. We curated some of the resources and we make sure that are things that are meeting some of the social needs of cancer patients. So there's things in there where it's you could put the zip code, as well as whether it's childcare needs, whether it's looking for a food pantry, but just some great information. So again, this is available on cancer.org. We'll share the link with you guys. And I just wanted to highlight it. There's also opportunities to suggest other programs. If you see that it's not in your community, you don't see a program that is there, you could go ahead and on the site, you'll see a suggest area where you can suggest a program if it's not highlighted. But again, it's a great resource to consider as you guys are looking for programs and available to your patients. So as I move forward, I wanted to touch on some key things on cancer.org. First, one really important thing, which I hope many of you are aware of, is our partnership with ASCO. So in June, we announced our collaboration with ASCO in uniting our efforts and making sure that we're making things simpler for where patients can go to find cancer information. So cancer.org is now a collaboration in collaboration with the ASCO. They provide medical review and contribution to our content, which is fantastic. We're making sure they have over 200 editorial board that advises with the American Cancer Society. And we have amazing resources that we're putting together that are available to you free of charge, ready to download. On my next slide, I'm going to highlight over the next couple of slides just some of the things that we have available. And we'll also share a handout or a flyer that has all this links and all this information available to you. Number one is all the information that we have through the entire cancer continuum. So we have information easy to read as well as in-depth information that touches on cancer prevention, risk, as well as screening. But we also go into understanding what happens at a diagnosis, what cancer treatment types are available, and a lot around the area of support services, a lot around symptom management as well. And what's important for you guys to know, especially as healthcare professionals, you care a lot about the quality of information. The American Cancer Society reviews and has an editorial process to make sure that our information and statistics are regularly being updated on a timely basis. Every year, our statistics get updated on our site. We keep an eye on FDA drug approvals as well to make sure that we're up to date in that information, and all content goes in a regular editorial cycle for updates. And I'm mentioning that just to let you know that when we say that we're reliable and the most trusted source is because we put a lot into making sure that the quality of the information we're putting out there is the latest as most accurate information. Another great tool that I find that it might be helpful is the Anatomy Gallery. The Anatomy Gallery provides you with, we have several systems, so like the endocrine system. So if you're wanting to cover with a patient on an animated 3D animation, you can actually talk to the patient and show them, you know, where the thyroid is and kind of understanding why it might impact their voice box because of the treatment or whatever is going on. We also have animated animations for specific treatments like a skin biopsy, a port used during cancer treatment, what it looks like for external beam radiation treatment, as well as things like screening with the low density CT. So this is an amazing resource. We're putting the links for you on the chat. On our next slide, I wanted to also share our materials for your patients. Again, we have a number of series on symptom management, easy to read. When we say easy to read, we're talking about we have them at a grade level of six reading level. Our What to Do series is the what to do for nausea and vomiting, what to do for pain, what to do for mouth sores, hair loss. It's great pieces that provide key information for your patients. We also, and I'll share, and I'm getting ahead of myself, we also have those pieces of What to Do series in 13 languages. We'll share that site with you on the next slide. But before I go to that, we also have our patient programs and services that has been mentioned. We talked about Road to Recovery, but we also have our lodging during cancer treatment. All the sites are provided to you on the handout that you'll get, as well as the presentation. On the next slide, I just wanted to highlight some of the 13 languages that we cover at the American Cancer Society that are the most common non-English spoken languages in the United States. On the additional resources, for those of you who want to get involved in other areas, we also have our American Cancer Society roundtables, which you can access through cancer.org and get additional information. There's also professional materials for you. There's trainings that we have done in the past. For example, our clinical caregiving toolkit. It's available on our healthcare professional site. The healthcare professional site was put together for you as our audience, making sure that you had access to things that are going to relate to you in terms of your professional growth and learning opportunities to keep up to date on journal articles and things that are coming out in the cancer space. But then we also want to make sure that you had easy access of going to this landing page and getting access to our education materials that you can use with your patients to educate them from prevention and screening, but as well with symptom management and understanding their diagnosis, as well as nutrition during cancer treatment, living with cancer after treatment, physical activity. I mean, I could go on and on with the things we have. We've also have been very intentional in adding content around cancer biomarkers, looking at things like right now, medical cannabis is an area that is starting to change, and we're expanding that content. So we're always looking to see what are the things that are being searched and patients are looking for additional information. We also do stakeholder feedback to make sure that we have a pulse on what the needs are for our patients out there. So I hope that you visit our site. You have your ACS staff partners also who are more than willing to help you get your fingertips on this information. But again, cancer.org is meant to support you and support cancer patients. And I think that's my last slide is next. Oh, I should highlight this. Of course, we take pride in what we do, and we've heard it from our patients. we have so many testimonials of where patients have been so grateful that have taken the time to write back to the American Cancer Society for the information and support we have been able to provide them. So I just wanted to highlight just 2 quotes of what is many that we receive. We really make a genuine effort to make sure that we're providing things in an easy to understand manner, and that the navigation of our site is easy for our patients as well. Thank you so much for your time today. It's a pleasure. I love talking about cancer.org. It's something that it's a proud product that we have, and an opportunity to make sure that we're sharing with you all. And thank you for the presentations today. I really learned a lot from you.
Thank you so much, Maria. That was wonderful. And it's such a wonderful resource, cancer.org. So thank you for giving us that overview with that. So thank you. Okay, so we have a final poll question. Hopefully it will come up after hearing from our excellent presenters. How confident are you with your knowledge of social determinants of health and the issues that surround them? So hopefully it'll come up. And we've been having a little bit of technical difficulty with the last few poll questions. So sorry about that, but that's okay. I know I learned so much, so thank you. Appreciate it. So please join us for our next virtual forum on September 19th. We will be discussing navigating issues in cancer survivorship. The CME certificate will be sent out in 2 weeks once you've completed the post-event survey, and the survey will pop up at the close of today's session. You will also receive a post-event email with the recording of the session and the survey link in case you missed it this morning. So again, you'll get all that. And thank you again for joining us today and for your commitment to end cancer as we know it for everyone. Thank you, everyone. Have a great day. Bye-bye.